Well, hello, everybody. We're back again with a great update. And we have Dr. Brian Bruinswicz. I didn't do it
You got
right.
it.
It was close.
You're getting better and better each time.
Each time, right. And we're going to have Dr. Bruinswicz. I'm going
You
to
call me
get it.
Dr. B. You
Dr.
can do
B.
Dr. B.
Dr. B.
We're going to have Dr. B. First, would you tell us a little bit about yourself and how you got into explanting?
Yeah, I'm a board certified plastic surgeon. It's been 98. I finished residency in 1992. I hate to go and count the number of years, but have been doing this for a while. I had the unique experience when I started my plastic surgery residency, and then towards the end of it was 1992. So this was when the implants were pulled off the market for the first time. So that was a huge, huge, disaster change for plastic surgeons at that point. And you started like back then you wanted to find out something about it. You had to go do a literature search, go to the library, find the journals or articles or books, copy text or everything to read about things. There was no way of getting information anywhere near as quickly or as fast as we can. So even back at that time, and there were case reports, limited series, some retrospective reviews of people that were having issues with silicone implants even back then. So it's been around for a long time. It was very interesting living through this whole thing. I obviously having put implants in and doing breast reconstruction. If you do enough of anything, you see pretty much every complication that can happen in the book. So just, standard complications for breast implants you would see and treat. Issues with capsular contractures and people having pain with those contractures or malpositions. Everything we were taught in residency was when you have a complication from an implant, a foreign device, you take the implant and you take all the scar tissue out with it. So it was one thing we were always taught as residents, same exact, teaching and all. If somebody had like a chronic wound, like a pressure sore or a burn, you got to cut out all the unhealthy tissue, get back to healthy tissue and start from there. So the whole idea of doing a capsulectomy was not a new thing. It was what, you reserve when you had a complication from an implant. So my first patient was about 5 years ago, and she was one of my patients that had a smooth saline breast augmentation and did fine for probably at least a good 10 years or so. And then she came in and educated me, started telling me what was going on with her health, which was deteriorating, mostly neurologic symptoms, had been to multiple specialists, had every single workup done. Nobody could figure out what was going on. And basically, she wanted to get her implants out and, the capsules, we talked about it. And she was the first patient and did her capsulectomy, took her implants out. Interestingly with her, she got initially better. And then it was about a year or so later, had a significant relapse and rebound. And it took a good year again before she started recovering. But I mean, she got better, has consistently stayed better. She was the first. And then one person tells another one, two tell four, and it's just exploded exponentially since then. And like I tell every patient, I wouldn't be doing this operation if I was hurting people, if I saw high complication rates with it, or if I saw that people weren't getting better. I mean, if it was a 50-50 improvement, like a coin toss, you got to be careful with what you're doing. And that's not what I'm seeing. Not, initially, that was basically the main impetus to write the retrospective paper, is to present our first 250 patients. And even since then, we're still seeing the same exact consistent results. So I keep taking implants and capsules out for people that are sick from them.
And we all thank you for doing that. It's quite amazing what you published, especially when it comes to, well, there's several things, but for those who are joining us, we put in the link in the announcement for this evening, and we'll put the article in the link for this live as well. And it's the article of outcomes of implant removal and capsulectomy for breast implant illness in 248 patients over about 4 years, correct?
I think I got the paper here, so I got to look.
Yeah, no, I think it is. I took
you
little
probably know
notes.
better than me, but 4 years is probably correct. Yes.
Well, August roughly, right? So maybe 3.5. August 2016 to February 2020. That's a lot, especially for those years, because now, I mean, it's growing, the explant awareness and the
Correct.
BII awareness. But I think that's significant. And what's significant is, and I'll let you summarize, but the geeky things that I really like was that you saw, and then you allowed us to see that it's saline and silicone innards also had, hello Tara and welcome, also had silicone in the capsule.
Correct.
And then jumping to, and what blew my mind is we know about the shell, and we know saline. There's many people with BII with saline, but now we have like literal objective data to say, hey, yes, look, silicone is in the shell, and that silicone gets into the capsule, which in my opinion goes to the body. And next week,
once it hits that capsule, once you get that in the tissues, it's basically systemic. I mean, your body's exposed to it, so you don't know where it's gone or where it's been.
Yeah, and the capsule is now scar tissue. I mean, it's bodily tissue. It's something your body has to deal with, right?
But it's also, yeah, correct, and it's living tissue. It's your body's response to a foreign object.
Yeah.
Capsule is not an inert substance. It's basically collagen. You've got fibroblasts, myofibroblasts, blood vessels, lymphatics in that. So, yeah, I mean, it is, it's your body's protective mechanism and barrier to that foreign object, but it's also in contact and part of your body.
Right. And so, and I can't wait for future studies to then say, hey, how much? I mean, I would love to, at some point, if you ever did a video of what does inflamed tissue look like? How do you know how to, debride, if you will, that area or cut away that area?
It's not necessarily, I mean, the capsule is very distinct and different than any other tissue, in the chest wall related to a breast implant or any other implant anywhere else. I mean, capsule is, I mean, it looks like scar tissue, or if somebody's, in the medical field, dense connective tissue, fascia, it has a different look and feel to it for most parts. It's very distinct. So, I mean, it's easy to see that's not a normal part of the anatomy for that part of the body.
Yeah.
I have a quick question. How hard is it to remove the capsule? Because some plastic surgeons say it's extremely difficult. What is your findings?
It's a tedious thing to do. It is tissue made by the human body, so most of the times there is not an easy separation, tissue plane between capsule and native tissues. If you think of other parts in your body, like the skin on your face or muscles when they slide and move, it's a looser connective tissue that allows for that slippery slide and all. Capsules, rarely you see that. They are distinctly glued and part of the tissues, and you have to basically cut them off. I mean, you can cut them off with a knife or a scissors. The problem is things start to bleed and you can't see what you're doing. That's when you can injure things. So, I use an electrocautery or Bovie cautery that we use in the operating room like we do for most of our procedures, because you don't get as much bleeding with it, so you can see what you're doing, but you have to cut the tissue away. I mean, it has to be surgically dissected free from tissues. The hardest part of getting that capsule off is, if an implant's so muscular where it's sitting on your chest wall and your rib cage, because, on top of the bone of the ribs, there's not a lot of tissue that you have extra to play with. It's basically a very thin layer covering the bone that you can sacrifice. Same thing with the muscle layers between the ribs, the intercostal muscles, or, the deeper muscles like the pectoralis minor on your chest wall. You basically take that outer covering, the fascia, off to make sure you get all the capsule out. It's tedious, and you have to pay attention. You got to be careful what you're doing to get it out. Tedious or difficult, it depends on, which word you want to use, but it takes time.
Yeah, and I believe, how do I say it? Access point is, it's got to be ample so you can see all the way up to wherever
exactly. You want to make a big enough incision that you can safely do the operation and get the implant and capsule out. I don't make huge incisions. The bigger the incision, the easier it is to take the capsulectomies out. If somebody's getting a breast lift at the same time, I got a much bigger incision to work through. I can take the capsules out more quickly that way. That's why it doesn't take that much longer to do the lift. You know, if you're doing a small incision under the breast and there's a big capsule, yeah, it gets more difficult, challenging. But I mean, I haven't run into a situation yet that I've, you know, had to leave, you know, capsule behind either because I couldn't get it out or I thought it was in a place that, you know, if I tried to take it out, I was going to hurt the patient. So sooner or later, I'm sure it's going to wind up happening, but I haven't quite had that happen yet.
Yeah, you know, I wonder, and at that point, if you can't get it out, you can't get it out, right? And
you can't. I mean, and that's, I mean, if I couldn't or I was worried, you can't really try to cut it away. I mean, that's when you would probably, you know, take the cautery and just cauterize and try to burn and just desiccate and destroy the capsule, the surface that's there. So, but yeah, I mean, right, you know, initially on a couple people I did do that with because I was concerned, but since then I take everything out.
And you feel that definitely helps the patient feel better afterwards compared to leaving it in? Just curiosity.
You don't, I mean, I think so. I think for a couple, I mean, it's what we've always done for complications from an implant. It's what everybody's been doing for people that, you know, have breast implant illness syndrome. Nobody's ever tried to do a study or like this one, I'm going to take capsule out, this one I'm not. You're probably never going to get a patient that's willing to sign up for that. So we really don't know. That's the big question, is how much capsule you have to get out, how important it is. You know, I think it is. I mean, I will still keep doing that. The other side benefit of cutting all the capsule out, when you do that, people tend to heal better because you have a big raw surface inside. Things just tend to contract straight back into their chest wall. They don't droop and go down to the ground. So cosmetically, yeah, I think you get a better result from taking the capsule out. Also, the secondary benefit of doing it all. But until we know more and we get more studies out there, exactly what role the capsule is, you know, plays, what percentage of people have, you know, silicone in those capsules, either that grossly you can see on pathology or that you can't, or, you know, now diagnosed radiographically. Those are the things that we need to know. And are still, you know, there are some studies out there looking not necessarily at silicone, but, you know, fungal, bacterial contamination, doing PCR tests like we do for COVID to see if there's any remnants of RNA or DNA left from bacteria or fungus that, you know, could be triggering all this. That's the ongoing research right now.
good to know. I will digress just a little bit because I'm curious on your thoughts of what is it about the shell of smooth. We'll keep it to smooth because textured has a whole different ball game of concerns with it. But what is it about the shell that allows the silicone to get into the capsule? And I know this is maybe a little bit more hypothetical, but I'm curious, right? Is it permeability, diffusion? Is it, you know?
It's not, I mean, with a saline implant, it's not going to be diffusion like the gel bleed with the silicone implant, where those silicone molecules are smaller than the spaces within that silicone elastomer shell. So you do get leach across. You know, we know with saline implants, you always overfill a saline implant in the operating room because you're going to get the air to diffuse out, and there's going to be some water and stuff that's going to diffuse across that silicone shell.
I didn't know this.
Oh yeah, you always, if you don't overfill, that's when you get more folds.
Yeah, but I didn't know that someone's going to leak out. That's the part.
Yeah, you always put a little bit more in so you know it's going to leak and that you still have, you know, a soft implant with the results that you want.
So it must go through the shell then somehow.
I'm sorry, what say again?
It has to go through the shell then.
Yeah,
somehow.
Exactly.
Well,
and with the saline implant and, you know, getting silicone shedding, it's basically either mechanical wear and tear, like bending a paperclip all the time, that, you know, it's going to wear and break. You know, you're going to get, you know, breakdown. You're going to start, you know, shedding silicone molecules. The silax, I mean, the silicone shell, the molecule is really a tiny little small molecule that just keeps, you know, cross-linking and joined together with silicone. So sooner or later with that movement, you could get silicone molecules fragmenting off there. Could it be, you know, body heat, enzymatic degradation over time, oxidation processes? Probably. I mean, I'm sure all that plays into it. But, you know, in our study, when we went back and looked at our 248 patients, I believe there were like 10 patients that had gross silicone that you could see under a microscope in their capsules. 4 or 5 of those were people with saline implants that were intact, where there
Yeah,
was no implant rupture. So there's definitely some silicone shedding or gel bleed.
I find that just amazing.
That was probably one of the most, besides people getting better, which, is our positive hypothesis that this does work. And I mean, I think it still does, was that, the complication rates you can keep very low doing this. But from my standpoint, most fascinatingly was the silicone with saline implants, that there was, refractile material in that capsule, which was consistent with silicone.
Yeah.
And how did you do this study for the testing the capsule?
Basically, I mean, it goes to a standard pathologist. So they do their, the regular H&E stains to look at the capsule to see if there's anything that's abnormal. And just like looking at breast tissue for cancer, I mean, if they see capsule and there's abnormal breast tissue, obviously they're going to check for cancer. If they see lymphocyte infiltration into the capsule that, lymphocytes out of the ordinary, that's when they'll start doing the CD30 testing, ALK testing and all. So first you have to look at the tissue under a microscope, because if you just ran a CD30, you can get false positive results and not know why that, is showing up. So there has to be a pathologic correlation with that to be able to make a good definitive diagnosis.
And how could we get more plastic surgeons to test for that? Because that wasn't
if you're
something
to
I
test
was able
for
to
the
do.
silicone.
Yeah.
If you're taking the whole capsule out and your pathologist knows what you're looking for and they're sectioning, it's the pathologist that should be picking it up.
Okay. So as an explant patient, somebody could come in and go to their plastic surgeon and say, I want this to go to pathology and I want to know if there's silicone in it. I want to know, I want it dissected.
Exactly. I mean, and that's all you need to do. And, like anything, if you're sending tissue to a pathologist, this is why I send to the same exact lab. So these people know what we're looking for. If they just put on the slip, capsule from an implant patient, please look for silicone, please rule out ALCL, they definitely will do that.
Okay. Right. Is it expensive?
The regular test, it's a regular pathology exam. There are other types of special stainings you can do to look for silicone outside of tissues and like macrophages. So that probably is a little bit more tedious and takes time. I honestly don't know how much the marker things like the CD38, other tests that they run, it runs up the price, but is it worth it? Yeah.
Agreed. I agree. Yeah, a little digression. I had a about 2-3 years out, I had one of the drains on my left side was removed a little too soon. So I had developed a seroma. Mm-hmm. It was a total capsulectomy. Like 3 years later, I decided to go have a mammogram because I hadn't had one in for like 8 years. And now I didn't have breast implants, so I thought I would go get one. And they found the seroma. And oddly enough, I had physical limitations on my left side. But I thought it was the surgery or remnants of, BII and the gift that kept on giving with breast implants. So when we removed it, we actually looked at the capsule surrounding the seroma, and it was filled with silicone, which I found very interesting. And this was I think the seroma was a year ago this past March, so almost 2 years now from that. But so when I read your article and I saw how silicone was in the capsule and how relatively easy it is to do pathology to see that silicone may or may not be present, I was like, isn't this intriguing? And it did get me to think about removing all inflamed tissue. But then I saw Deachcombe's article and how, his was on silicone implants, but how silicone was found in the capsule and the lymph. And I think as providers post-explant, that gives us a lot to work with. So I thank you for that.
No, and it's true. I mean, my numbers were small. His numbers were much. It's eye-opening reading his paper and seeing the number of people that did have percentages that had silicone within the capsules, and like in your situation too. I mean, that the scar tissue that formed around your seroma, that's a capsule. I mean, right. Your body, it happens when tissue is abnormal. So yours was contaminated with silicone, so your body wasn't going to resorb it. If there was bacteria or something else there, same thing. You could still see residual capsules. If that fluid was completely normal physiologic fluid from being injured, yeah, your body should have resorbed it.
Yeah. No, it's quite intriguing. And I know we had talked briefly before we started this live about silicone-induced granulomas as seen on MRI. And there was a silicone-induced granuloma seen on the MRI that I had.
Interesting.
And you know, that's a whole other podcast we can have. But welcome, Tara. I don't think we officially welcomed you. Nice to see you.
Late to the party. Hi, Dr. B.
How are you doing, Tara?
Good. How are you?
I'm doing well.
Thank you for this. This is.
Oh, you're more than welcome. The more people, the more discussion you can have, and educated discussions about anything in this world, the more we learn, the better it will be.
I also just want to point out behind the scenes, because Dr. B is a pretty humble man. He's not going to let you know this, how hard he worked to get this information published. So it wasn't just the hard work that it took to do all this research, but then actually getting someone to say, yeah, let's publish this. I know that was a huge feat in and of itself. So thank you for not giving up on our community and for all of that you do, because it's really.
No, thank you. And again, I mean, this was published in the Plastic Surgery White Journal, Plastic and Reconstructive Surgery. They're online, Plastic and PRS Global. So, you know, they're web-based journal, basically. It took a little while to get it accepted there, but I want to thank the people, the editors and reviewers that looked at our articles, because they made very good constructive criticism. We go back and tweak the study some, a little bit more. We got to the point finally that they were comfortable and happy publishing it was a good thing. And, you know, and rightfully so. I mean, retrospective studies, they're basic limitations right out of the gate before you even start. So you have to be honest and fair and point those out in your article. They wanted to make sure things were very clear. So yeah, I'm happy it got there. It took a while, but yeah, we finally did it.
Awesome.
Are you still continuing the study then?
We have, thank you for asking. What a wonderful segue. That was the initial 248 patients retrospectively looking back at them. After that article, we did apply to the Institutional Review Board at, you know, Abington Jefferson Health System. We are approved and have an ongoing prospective study going on. So this is basically the same exact thing where I'm going to go back retrospectively and look at, you know, capsules, pathology, infection rates, and complications. But most importantly, one of the biggest criticisms of the articles was the follow-up. Did people get better? What percentage of people responded? So this is a prospective survey study that the patients that are involved are, you know, filling out a more detailed questionnaire preoperatively. Probably by, you know, the end of this year, I'll be starting to send out the postoperative questionnaires, asking the same questions. Are they feeling better? Did they have complications? Was this work doing? But, you know, extensive questionnaires, and it's all patient-driven, patient responses. It's not relying on me going back and looking at my medical records and charts and trying to figure out whether it worked or not. So it'll be a much more powerful study. As of today, we have 96 patients enrolled. So we are probably close to having, you know, statistically significant number of people, and we're about a year out. So, you know, we get at least a good 6 months average or more follow-up with these questionnaires and a high percentage of return. It'll be a very powerful paper.
Yeah, absolutely. And I would, hopefully everyone will be engaged to help you fulfill on that, because we don't have the post-market approval studies. We don't have that data from any of the manufacturers at this day and time. And it's been quite a while.
Correct.
So I'm sure we can help find you an army.
The patients have been, honestly, you know, they've been very, very responsive and helpful.
Wonderful. What I found really interesting is when in table 1 under the patient characteristics with autoimmune disease or autoimmune diagnosis, you know, arthritis was about 27%. And I'm saying this for most of the practitioners that are out there, especially the functional medicine practitioners. Listen to this. arthritis, chronic inflammatory response syndrome, lupus, Sjogren's, Raynaud's. I mean, there's more on here, but I'm going to the higher ones. Hashimoto's, anxiety and depression. Of any functional medicine practitioner out there, or integrative practitioner, or primary care person, how many of your patients have these symptoms and have breast implants? Like every one of my clients, not all of them have breast implants, but they have these symptoms. And when I'm specialized in BII, right? So it's a larger population. When they come to me with these symptoms and have breast implants, these change. I won't say they get all better all the time and that people don't have flares, but their quality of life scores and their vitality shifts when the explant happens. And I don't know that I've ever appreciated, 27% for arthritis in the BII population. That's a large number.
And these are what people were putting on their initial intake questionnaires when, their consultation, when they become a patient of mine. And we had a separate 4-patient questionnaire going in more detail about breast implant illness symptoms. So these are ones that people were writing down and self-reporting. This was not, us going back and saying, well, my joints hurt, that's arthritis. This was a self-reported thing.
Yeah, no, I still think it's great. I would love to know in your prospective, whether it's this one or the next one, like, did they have these symptoms at time of implant as well? Like to know
Most
when.
don't.
Yeah.
Most do not. Most of the majority of the symptoms happen after the implants. The only one I can think of that people do have ahead of time but gets worse with implants is anxiety or depression.
Yeah.
You will see people that are very functional, doing fine baseline. They know how to control things before implants, and then all of a sudden things just go out of control. That's the one that's the most common.
Yeah. Oh, I fell into that, and I was not an anxious person or depressive person prior to implants, and then 3-4 months in, like things just got a little bit more challenging, and so on. How about for you guys, Tara?
Oh, I was a mess when I had my implants. I couldn't do normal things. I didn't even drive anymore. I stopped driving because I was so stressed.
Yeah, same way. I went from being very going, very energetic, and then not wanting to leave the house.
Yeah.
Very common.
And it all went away after I got my implants.
Yeah, I was gonna say, now I drive, I'm running, I'm out playing, I'm a happy girl.
Same. Those were my big take homes for the paper, and just to say thank you for being here. I do have one other question. When we look at the like the total AEs, I think you broke them down in the paper. But I'm curious. It was such a low risk in my mind that I hear other surgeons may say, oh, it's a higher risk. I think this was this paper.
It was. I'm looking for it. I don't know if we have a table for complications or it was just listed in there.
I think it was just listed.
Results. I'm looking through some results.
Because I was really, and you were really, I mean, you disclosed everything, which is great.
And that's probably the most, from my standpoint, the most important thing, and the thing you have to be as honest as possible are complications. I mean, you're saying you're doing this operation. It's critically important to know how dangerous it is and how people do.
You have it in the results.
Yeah.
And for me, it's not, it's not that you want a 1% risk, you want to limit the risk all the way around, but
correct.
These are acceptable risks, even when you add them all together, is my point.
Correct. And most importantly, and God forbid, nobody has ever died from this operation. We've had some complications that could have been serious. From my standpoint, the most serious ones were the blood clots in the legs and pulmonary embolism. Both of those were patients that had, risk factors for getting blood clots, previous breast cancer patients, previous operations, other health conditions. So sort of a setup, but, none of those people did badly. The most dramatic, which everybody asked me, are the 2 pneumothoraces that I gave, getting into the chest cavity. I mean, it was part of the learning curve, taking the capsules off. It's a dramatic complication when it happens in the operating room, but it's an easy one to fix if you just know your basic general surgeries, how to patch that hole and reinflate the lung. So again, nobody had any issues that were permanent for them long-term or significantly disabling that the recovery was impaired with it. So yeah, it's a critically important thing. You don't want to sign up for a dangerous operation that may or may not work for you.
So true. Yeah, you guys have any other questions? Do we have any live questions?
No, I looked. No questions yet. I'm sure there will be.
Yeah, and we'll tag you or have you off. I don't know how you do your social media, but if there are ones we can't answer with quotes from the article, I will gladly like to forward them to you.
I will make you forward them, email, phone, whatever. If it's through social media, there is somebody in my office that does check. So if there's questions that come through, they will let me know.
Wonderful.
And I'll make sure that I answer and get back to them.
Well, thank you, Dr. B, again. And
you're welcome.
How do people get a hold of you if they want to consult with you, or do you have, can we list an email?
You can either call the office. If you just look for me on the website, you'll get my webpage. You can call through there. I think you can schedule an online consultation or request through the website. There's a phone number on there that you can get somebody pretty much 24/7. So it should be relatively easy to call and make an appointment. I'm almost positive my email's on there, to contact me, like Dr. Brian at Bruinswicz Plastic Surgery. I'm easy to get a hold of.
Okay, great. All right.
Sometimes too easy, but I'm easy to get a hold of.
We also have Tara's Facebook page that has a lot of information that we can put. Yeah, we'll put your link in the comments as well.
Absolutely. And if you guys will just hold on a little bit, I'm going to come off of Facebook Live and thank everyone for joining, and we'll see you next week around
Thank
the
you
same
very much.
time.
This was an honor.
Thank you. And let me stop recording.